Chapter 23, Assessment of the Pregnant Woman. Introduction to assessing the pregnant woman. Assessment of the pregnant woman at regular intervals contributes to overall well-being, maternal as well as fetal health and well-being. Pregnancy is divided into 3 trimesters, and the average length of a pregnancy is about 40 weeks. Pregnant women experience profound anatomical and physiological changes during their pregnancy. Skin changes include chloasma, which is just the mask of pregnancy, spider angiomas, striae, which are stretch marks, pruritus, which is just itching, generalized itching, and then hirsutism, which is just hair growth found around the areola, in the neck region, maybe in the chin region as well. Musculoskeletal systems. Strain is placed on the axial skeletal system as well as the pelvis. With the influence of progesterone, all of their bones and muscles start to stretch. They start to kind of soften up a little bit, and so they're gonna complain of a little bit more strain and tenderness, especially in their pelvic region. Lordosis is very common in pregnancy because their center of gravity shifts forward. So lordosis is just that exaggerated curvature of the lumbar region, and they'll complain of pain in their ligaments, the pubic bone, cramping in their legs. The breast and reproductive system, simply I like to say, is their breasts are preparing for lactation. Their body is pregnant, and so their breasts are going to get more enlarged, more uncomfortable, and there'll be changes in appearance, and this is under the influence of estrogen and progesterone. And sometimes colostrum can be expressed around the 16th week. The uterus changes to more of a spherical shape, where it was more of a fist shape in the 2nd as well as in the 3rd trimester. Usually palpable around 12 to 14 weeks, and it enlarges 1 centimeter per week. Cardiovascular and respiratory system, those are the 2 systems that start to overwork. In the cardiovascular system, there's about twice as much blood in their body as if they were not pregnant, so blood volume does increase by about 40 to 45%, and that's really to support the growing uterus, the placenta, and the fetus. Their clotting factor activity is suppressed, and therefore it makes them more hypercoagulable. They're more at risk for deep vein thromboses. There's also that estrogenic effect on the respiratory tract, capillary enlargement. As their uterus grows, it grows up, and so their tidal volume does decrease a little bit. Their progesterone levels also impact their tidal volume. They might not be able to take as deep a breath as they used to. Psychological concerns include anxiety, depression, mood changes, and these, baby blues don't necessarily occur after delivery. They can actually occur during pregnancy. And it's just the influence of estrogen and progesterone. Increasing levels of HCG, which is the pregnancy hormone that's released by the zygote. Some people are more, sensitive to that HCG level, and it makes them nauseous. Constipation, acid reflux, urinary retention, frequent urination, all influenced by progesterone. And progesterone slows everything down, including the gastrointestinal system. So that's why constipation is very common in pregnancy. Signs of early pregnancy can be presumptive. Presumptive is they're subjective, like I think I'm pregnant because I missed my period, or I'm tired, or I'm nauseous, I'm peeing a lot. Probable signs are those that are more objective based. Discoloration of the vagina, cervix, enlargement of the abdomen, cramping. Positive signs are simply you could see the baby by ultrasound, you can hear the baby by Dopplers, and you actually have fetal movements. Mary Jane is 28 and reports that her menstrual period is late. She talks to you and tells you that she's fatigued, How do you confirm that she's pregnant? Which of the following tests will be a positive sign of pregnancy? If you said ultrasound, you're correct. Which symptom of early pregnancy indicates a need for careful follow-up and monitoring? If you said shortness of breath, you're correct. Going back, nausea is very common in pregnancy because of the HCG levels. Constipation, again, very common. And then leukorrhea is just white vaginal discharge, which is also very common. Terminology that you should know, and go back to your anatomy and physiology days and your health history assessment, your GT-PAL, your Gravida T-PAL. Your gravida simply means is the uterus pregnant, and how many times has the uterus been pregnant. It doesn't matter how many babies are in the belly, it just matters whether or not it's a pregnant uterus. And parity simply is the shorthand of the TPAL, which is term pregnancy, preterm pregnancy. A is your abortions, ectopics, anything under 19 weeks. And then L is, your living children. Please refer to box 23.1 for all of these terms. Your Nagel's rule is more of a shorthand way of assessing a pregnant, the expected date of delivery, and this is really based on their last menstrual period, which is the first day of their last menstrual period. And what you're doing is you're taking the first day and you're subtracting 3 months and adding 7 days. And you're just using numbers, and identifying this. So an example of this is if their last period was December 1st, you're going to subtract 3 months from December, which brings us to September. And then you're going to add 7 days to the 1. So 7 plus 1 is 8. So her expected date of delivery is September 8th, and you're going to change the year, of course. Confirming pregnancy can be done in a couple of different ways, but the most definitive way is your ultrasound. These HCG tests will tell us that they're probably pregnant, but we're not going to know for sure until we actually visibly see a pregnancy in their uterus or outside. Routine diagnostics with pregnancy include CBC, a type and screen. We want to identify viral titers such as rubella and varicella. Genetic testings are also included with their tests. Cervical cancer screening or pap smears are done if they're eligible for. If they've had it done already the year before, they might not be. Sexually transmitted infections are also assessed for. HIV as well as hepatitis, which is not listed here. And then urinalyses are also done. For gestational diabetes, they usually do at around 26 to 28 weeks a glucose challenge test, which is simply a fasting and then give them an orange, soda pop drink, and then they test their sugar again an hour later, and it should be below the 140 mark. If they fail that test, then they get an extended, more of a diagnostic glucose tolerance test where, this is a longer term test of fasting. They drink something sweet, and then their blood is tested 3 times, an hour apart for each 3. So hour 1, hour 2, and hour 3. For the tolerance test, they would have to fail 2 of the values to be diagnosed as a gestational diabetic. If you said D, you're correct. So it's her third pregnancy. She's pregnant, so we include that with the gravida. She hasn't had any term pregnancies. She did have one preterm pregnancy, and she had one miscarriage, and she currently has one living child, and that was that preterm. The challenge of a review of systems for pregnant women is really to differentiate normal as well as expected changes from abnormal or concerning problems. And again, we're always using, our old cards or QRST, whatever your preference is. Normal pregnancy discomforts include nausea, vomiting, food aversions, reflux, constipation, maybe a little bit of a racing heart. Their pulse may increase slightly. They may feel a skipped beat. They may be very tired. The shortness of breath might just be because their diaphragm is being pushed up and they're not really able to take a deep breath, versus shortness of breath where they can't breathe. So you gotta kind of differentiate between, are they short of breath because they can't breathe, or is it short of breath because they're pregnant? Breast tenderness are very normal. Sleep, mood, and libido changes are also very common. Going back to the heart racing and heart skipping, we always want to make sure that they don't have an onset of a new murmur. We want to identify what their appetite looks like, what their typical diet is, what type of diet do they follow, if any. Are they vegan, vegetarian, pescatarian? What are they? And then make sure that they're consuming the proper amount of minerals and nutrients that are needed to, gain the adequate weight that they need for the pregnancy, but also are intaking what they need for themselves and their pregnancy. You want to identify what medications they're on, if there are any substance use or abuse. What are they exposed to? What environmental exposures are they, exposed to? Accidents, falls, or are there any animals in the house that could be a trip hazard? We also want to discuss with them around 26 to 28 weeks about fetal movements and what is normal. We want to talk to them about danger signs of pregnancy, vaginal bleeding or leaking of fluid, or severe cramping. Prenatal care in the United States follows a prescribed plan usually, and it's a case-by-case basis most of the time. But usually within the first 28 weeks, they're seen once a month or every 4 weeks. From 28 weeks to about 36 weeks, they're seen every 2 weeks, and then from 36 on, they're seen on a weekly basis. During, our prenatal visits, as always, we want to maintain dignity, privacy during our assessment, and we're only exposing the part of their body that's required to be exposed. Every subsequent visit, it's just their abdominal region that's being exposed, so that we can measure their abdomen, making sure that their fundal height is growing normally, one finger or 1 centimeter a day, and we're listening to the baby's heart in the office. We want to, keep the room well lit, warm, comfortable, and wash our hands. When they come to see us, we do a couple of different, basic exams. It includes vital signs, a urinalysis, weight measurement, and then an assessment of their abdomen. So just review for vital signs, review how to collect their blood pressure, their height and weight, and an expected weight gain should be about 4 pounds within the first trimester, up to say week 14, and then 1 pound from weeks, for every week. Normally, they should gain between 25 to 35 pounds for normal BMI. If they're underweight, we want them to gain a little bit more. If they're overweight, we want them to gain a little bit less. Appropriate weight for pregnant women of average height during a healthy pregnancy is and I just gave you the answer before. 25 to 35 pounds is the correct answer. So when we're doing our general assessment, we want to emphasize the normalcy and changes associated with pregnancy, such as the skin changes that we talked about earlier, texture and distribution of hair, looking at any stretch marks, any congestion, nasal congestion. Remember, twice as much blood in their body, they're going to be congested. They may have gum bleeds, nose bleeds. Their vaginal area may also be congested. Their diaphragm is going to be elevated. They might not be able to take those deep breaths. And they may have a couple of like a rapid heartbeat or heart palpitations. And it's all related to just that fact that they have increased blood flow in their body. We're inspecting and palpating breast tissue for any changes. Go back to chapter 18 to review how to properly assess the breast. And again, looking for any abnormalities. We're also looking at their abdomen, assessing for any pregnancy-related changes, colorations. Sometimes they'll have a line of pregnancy or the linea nigra, which is just a darkening line from their umbilicus to their pubic bone, and that's very common in pregnancy. It's the linea nigra, and it's just increase in melanocytes. Palpate the abdomen, identifying the organs, but more importantly, palpating for any contractions or firmness of the uterus. Palpate for fetal movements, and then identifying fetal position. And this is usually done by Leopold's, towards the end of their pregnancy. It's usually not done mid-pregnancy. Normal abdominal findings, stretch marks, linea nigra, palpating contractions, movements of the fetus, and the baby is vertex or head down. When we're measuring the fundal height, we're measuring from their pubic bone all the way to the top of the uterus, also called the fundus. A normal fundal height should be centimeters, equaling the number of weeks that they are. Usually around 20 weeks, their measurement is right at the umbilicus. And we're listening to fetal hearts using a handheld Doppler or Doptone. And the way to find the fetal heart is just simply identifying through Leopold's where the baby's back is, and then applying the Doppler right where we find the back. And we're auscultating. Box 23.5 has definitions on fetal monitoring. Let me just go to it so that, let's see if I want to speak to it, where baseline is 110 to 160, normal baseline. And we're listening really, when we're doing a listen through the Doppler, we're really just listening for heart tones, and we can't identify the variability. We can't really identify any other factors closely unless we put them on an actual electronic fetal monitoring system. This should really be 110 to 160. Your book is incorrect by saying 120. So it's 110 to 160. So let me just make sure that you guys recognize that. Pregnancy and childbirth goals for Healthy People 2023 include preventing pregnancy complications, lots and lots of education, as well as, from conception all the way through the postpartum period. So a woman is 20 weeks pregnant. Where on the fundus should the uterus be found? And I think I kind of sort of gave you that answer. If you remember, I said the umbilicus. You're correct. And our last question. A woman is 32 weeks pregnant, worried because she's developed linear brown line below her umbilicus and is worried that something is wrong with her abdomen. What is your best response? And what did we say this one was? The linea nigra, which is a very normal outcome from an increased production of melanocytes.